So these are my disclosures. I've done a number of educational activities relating to DermScreen, either on an advisory board or a research reviews perspective. I've done speaking engagements, and most recently at GPCE and on behalf of Cancer Council, but also been involved in skin cancer screening programs myself, either through the Skin Hospital, DermScreen, and the Melanoma Institute. So in terms of what we'll cover tonight, I hope to warm up by discussing what's involved in a skin check and its role in early detection, how technology is changing the skin check experience, what is a skin health check at DermScreen and what does it look like, and what do the reports look like, and what does the patient experience, and how can GPs be an advocate for better skin health. I hope to leave a bit of time for a Q&A, and hopefully there'll be some good discussions, and look forward to hearing your thoughts and feedback. So what is a skin check? Many of you would have referred to a dermatologist for a skin check, a routine skin check, and you please do a skin review. But what does that actually entail? So what it means to me is that there is a full body examination, whether that's to examine for skin cancer, so skin cancer screening, or an overall assessment of a patient's skin health. So what that would mean is to examine whether there is any evidence for infection, any inflammatory conditions, or other situations whereby a patient wishes to improve their skin health. So it can be quite broad, and hence a thorough examination is always best. I thought I'd give you my technique on how I do a skin check, and it's different for men and women. The important thing is to be respectful, and the tips are to offer a gown, do it in stages, actually look at the patient and use your dermatoscope, and where appropriate, have good lighting. And particularly, I like to emphasize on examining hidden areas such as the scalp, ears, toes, and soles. I like to always start with the hands, so always have a non-confrontational. I always find that it is a non-confrontational approach rather than starting at the face. It permits a really warm and therapeutic relationship with the patient, and that allows you to then work your way up to the shoulders. I then look underneath the chin and the neck and the chest, and followed by under the armpits and the abdomen. So this is a very systematic approach to doing a skin check, followed by examining the back. So I always walk around and ask the patient to turn around, and I examine behind the ears and specifically tell them that I'm doing so, and that demonstrates that you're being thorough. I often like to run my hand over the posterior scalp as to, again, acknowledge that you've examined that area and demonstrate that you're thorough in the examination. It's also important to examine underneath the underwear, although very rarely you would actually see anything of suspicion there, and ask the patient to assist you by pulling the underwear down. So for example, what I often say is, show me the tops of your bottoms. And then whilst they're still standing and facing away from you, examine the posterior legs and actually tell them what you're actually looking for and where you're looking, if there's any abnormalities or if everything's normal. Again, it informs the patient that you have looked. For women, obviously, it's important to seek permission, ask if there's anything underneath the bra that you're worried about. And in particular, when examining my female patients, once the top half is done, I then get them to get redressed before examining the bottom half. Particularly when examining the head and lower legs, as demonstrated in the picture, I like to use either a chair or a bed. That allows you to be at the right level to examine difficult to examine areas such as the bottoms of the feet, as well as the scalp as well. In particular, ask them to open their eyes because it's easier to see lid margin lesions when their eyes are open, and then ask them to close them as well. And where appropriately, examine through the beard and scalp. These are the tools that I use. So always emphasize the importance of good natural light, but also a comfortable setting with screens, stool, chair, and bed. And these are some of the tools that I use in my practice. For those of you that are quite comfortable using dermoscopy, this is my approach when examining lesions. These are in a simplified way of thinking about the different colors that can present on dermoscopy. That's using a handheld microscope to look at specific lesions of concern. And they can be differentiated to whether they are pigmented or non-pigmented. And based off that, we can then determine whether they are of melanocytic origin or non-melanocytic origin. Using that as a schema of how you approach a lesion, that will help you to arrive at the correct diagnosis. Always be wary of the featureless condition, lesion, as this could represent a featureless melanoma. And the patterns for which these that you find in the textbook may change according to site. And I always feel the more you look, the more you would find. So these are some of the terms used to describe melanocytic lesions: networks, pseudonetworks, globule streaks, blue pigmentation, and parallel patterns. But some of the other entities that are relevant for dermoscopy are conditions like BCCs, hemangiomas, sebcases, and dermatofibromas. As mentioned before, featureless lesions are by default a melanocytic lesion, and in particular, pink or amelanotic melanomas can present in this way. Some of you may be familiar with the 7-point checklist or the Menzies scoring method for melanoma, and these are quite useful tools to help guide you to make and arrive at a correct diagnosis. Again, these are some of the schematic diagrams of some of those checklists. Again, these are some of the patterns that were discussed earlier, just for your to refresh your memory. Blotches, blue-grey dots, blue-white veil, and atypical vessels are generally considered abnormal findings on dermoscopy. I thought I'd present this particular paper, now over 10 years old, but importantly, in a primary care setting, the use of dermoscopy and short-term SDDI stands for short-term dermatoscopic imaging reduces the need for excision or referral of benign pigmented lesions by more than half, while nearly doubling the sensitivity for diagnosis of melanoma. So even using simple tools like dermoscopy can greatly improve the patient care and avoid unnecessary excisions and obvious scarring that results from that. Moving on to why early detection. There's some recent papers now, as most recently is 2022, demonstrating that delayed diagnosis of melanoma, not surprisingly, is associated with worsened overall and melanoma-specific mortality. So across all stages, treatment delays between 3 to 5 months were associated with worse melanoma survival, melanoma-specific mortality, and any delay beyond 1 month was associated with a worse overall mortality. So therefore, timely treatment and obviously timely diagnosis with subsequent treatment is clearly important against our fight with melanoma. Thinking about screening as a tool, this paper looks into the association between melanoma detected during routine skin checks and mortality. And if one was to look at the conclusions on face value, although there was a significant reduced in all-cause mortality, the paper wasn't able to demonstrate melanoma-specific mortality. What that meant was, in melanomas diagnosed through routine screening, the patients weren't actually having a mortality benefit as a result of having these regular skin checks. But if you were to look at the detail, the detail actually tells us that it's actually invasive melanoma detected during routine skin checks was associated with nearly a 60% lower melanoma-specific mortality. And the reason why that conclusion is the case is because it lumped together both quite low-grade melanomas, so those are melanoma in situ that generally have a very, very good prognosis, with very bad melanomas, so the invasive melanomas, and hence the study wasn't able to demonstrate an improvement in the melanoma-specific mortality. However, with invasive melanomas, they were able to do so. Moving on to how technology is changing the skin check experience. Over 20 years ago, in order to diagnose one melanoma, doctor had to, or a clinician had to excise 15 lesions to be able to diagnose one melanoma. With the advent of traditional total body photographs, and that's where using a SLR camera, one was able to reduce that number needed to excise to diagnose one melanoma to 10. Nowadays, with using dermoscopy, and those of you in the room who are very skilled at this will be able to testify to this, you've been able to reduce the number that you needed to excise to diagnose one melanoma to 5 biopsies to diagnose one melanoma. And then in the last 10 years with digital total body photography, the number needed to excise has reduced the number further to 2 to 3. So you only need to, and this is a level of diagnostic accuracy, this is what it's a reflection of, biopsy 2 to 3 lesions in order to diagnose one melanoma. So obviously times are changing. This diagram was really just to highlight some of the advances that are made with these types of technologies in skin cancer detection. You've got very large and very expensive devices to very inexpensive and more user and consumer facing devices to self-diagnose, to more AI-driven diagnostic capabilities, and somewhere that lies in between. This is a paper from the British Journal of Dermatology that demonstrates the utility of total body photography is that in best current estimates, it's suggested that patients at high risk of melanoma, total body photography has an acceptable number needed to biopsy. So that was the number needed to excise, or the number needed to biopsy that I was talking about before, compared to previous studies using standard clinical examination without total body photography. So this indicates that particularly when examining high-risk patients, such as those with lots and lots of moles or previous melanoma, there is a role for total body photography. And when you combine this with digital dermoscopy, so actually using a special connected hardware to actually take up-close photographs, it actually increases the reliability and the pickup rate even more. So the combination of total body photography with digital dermoscopy, so this two-step method, allows detection of melanomas in early stages with a significant reduction of excisions. And ultimately, as clinicians, we want to do what's best for our patients, which is to obviously pick up melanomas when they are there and avoid not biopsying non-cancerous lesions when they're not cancerous. And this review really just emphasizes that one of the most promising approaches of automated imaging of patients or total body photography is allowing objective documentation of all existing lesions and monitoring change over time. And I think this is very important and something that even myself as a dermatologist I can't do, which is actually objectively be able to demonstrate that a lesion has changed over time. And I'm often relying on the history of the patient to tell me that. So rather than showing papers, I thought I'd show you some of the photographs and the quality of the images that are generated by this technology. And these were some of the early days, many years ago, whereby I was using this technology, particularly at the Melanoma Institute. So some of you may have seen these images before, and because I find that they're very useful for educational purposes. So which is the skin cancer, A or B? Well, it's actually B. So that came out as a superficial BCC, and even without dermoscopy, although the dermatoscopic pictures is here on the left, one can quite nicely see that rolled edge of the superficial BCC that makes the diagnosis quite readily apparent. This is another example of a patient whereby there has multiple lesions, and I asked the audience how many skin cancers that she have. Well, you know, or is it a trick question? Well, she has actually at least 3 to 4 lesions that warrant further investigation. This came back as a nodular BCC, Bowen's disease, Bowen's disease, Bowen's disease. Again, where is the skin cancer? And this is how maybe to those that are unaccustomed to total body examination, where do you start? Well, the actual skin cancer is actually here on the shoulder. And lastly, looking at some of these examples, where is the skin cancer? Well, C is actually the right answer, and with dermoscopy you can quite nicely see these arborizing vessels of a basal cell carcinoma. So moving on to skin health checks at DermScreen Bondi Junction. What is this all about? Patients can actually make a booking, and in this instance, after you've written a referral, and make a booking online at two websites, either the Skin Health Check website or the DermScreen website, where there's a Book Now button, or the IMED Bondi Junction landing page, where there is a booking an appointment button there. When that is pressed, there is an online booking process whereby patients can fill in their details and book their appointment instantly. And this is the main difference to how patients are accessing these types of services. Traditionally, and often frustratingly, both GPs and patients find it very difficult to get in to see a dermatologist, and thereby I'm trying to solve this problem with IMED in order to make a skin health check a lot easier. And this way, at least, you can get some early information, like how you would with an X-ray or a blood test, so that you can make better decisions and refer appropriately, particularly if something is of concern and picked up by the skin health check. Or alternatively, if nothing is found or is all very reassuring, then it may actually avoid saving the patient actually having a face-to-face appointment with a dermatologist, which can often take 2 to 3 months in the eastern suburbs area. So when patients actually do book online, they can actually then fill in a number of questionnaires prior to their arrival. And this really allows us to ensure that the entire process is not only detailed, but very efficient. So they can enter in their personal details, their GP details, and this is critical to access the DermScreen service, as we want to involve their healthcare professional in this, and for the report delivery. Medical registration, their health fund, any specific concerns that they have, so they can actually mark on this mannequin any specific areas of concern, and then that would be appropriately discussed or documented in the report or addressed at the report. And of course, if you have filled in one of these skin imaging requests that have been sent to you recently, and if you haven't, please do let us know. They can actually upload a photograph of this. We also include a melanoma risk calculator based on the questionnaires and the responses from the questionnaires, and that will be further detailed in the report. And more history and more information about their medical history, their prescribed medications, whether they've used tanning beds, and any concurrent skin rashes that they have. They can certainly document all this, or any issues that may make the examination that may affect the technical aspects of the examination, such as laser hair removal or a sunburn in the last few weeks. There's a consent form, and for which they can sign there. So I'd like to now do a live demonstration. So this is exactly what I see when I'm actually reviewing these images, and this is an example patient, not a demonstration patient, not an actual real patient, so there's no issues around privacy there. But just to give you an idea of the resolution that we get with these images, we can really nicely zoom in on some of these areas, and this is even on a home internet connection. So we can actually pan it around and zoom out, and even look at different views as well. So you know, really the detail is very impressive, and I would never get this close to a patient anyway. So I'm actually being very pleased with how I've been quite comfortable reviewing these images and applying some of these filters to help pick up certain lesions as well. And this has been a real game changer when examining patients, because it helps me to highlight certain red lesions or brown lesions that warrant further examination. So hopefully that's been quite a useful demonstration to some of the quality that we're actually achieving with these technologies now. So going on to the report, this is an actual report, but obviously redacted, of a patient that has been through the DermScreen skin health check. They were concerned about something over the right cheek, and I've specifically addressed this in my report, saying that the right cheek is fine and there's a benign seborrheic keratosis. I've advised that no lesions require further action. And based on the questionnaire responses, this patient had a very much below average risk. I did have some incidental findings, which was a subungual hematoma, so a bruise underneath the nail on the left first toe, which was identified, and then recommended a next skin health check in 12 months. As you can see on the right, it's a very much a synoptic report, and takes a regional approach to and very systematic approach to skin examination, documenting the skin type, sun damage, hair and eye color, which are relevant for melanoma risk, and the mole count, and then any abnormalities across the different body regions as well, and incidental findings and whether or not the exposure was optimal for this type of report. These are some of the specific spot photographs that were taken of this patient, and we have a traffic light system whereby anything that is can be reassured is a green, anything that to be monitored is an amber, and anything that needs immediate attention is red. We've already picked up a number of skin cancers, mainly BCCs, through the Skin Health Check program, and it's been very helpful to really compress the time that it takes to diagnose and treat and then manage these lesions appropriately. So how to refer and how to get there. So this is the skin imaging request. So the patient details are at the top. You can either request not only for a skin health check, but also specific spots to examine. I'll explain what other doctors have done in the past. You can draw the areas and then add in some clinical details. For example, if they have a concomitant skin eruption that you're concerned about and would like me to specifically make comment to. And then obviously the requesting details. The email is actually very important because that's how the reports are delivered at this point in time. And then on the back of the page, the patients can actually book using this QR code. And this is where our contact details if the patient wishes to find us. Now, some patients prefer to just call up, and we have a reception available to take that patient's booking. So these are some examples of referrals that have come through. So whereby a doctor's requested a skin health check, or in this case, a doctor has specifically requested a skin health check as well as spots. I distinctly remember this patient on the right because it was actually referred by a plastic surgeon who felt that he wanted that reassurance of advising not to biopsy, because if she had to biopsy, it would be involving a very cosmetically sensitive area, such as the face or the chest area. So in this instance, we were able to tell the patient to be reassured and to just monitor the lesion over time, which is the whole purpose of what DermScreen's about, where appropriate, of course. So how to find us? It's at 3 Waverley Street. Parking's available through the Waverley Council Bondi Junction location or at Westfields, and it's at the left wing of the IMED Bondi Junction area. I've just prepared a video that we show our patients as well. So that was one of our senior melanographers, Lynn, who actually examines the patient and also not only takes the photographs, but examines in difficult to photograph areas such as the scalp, in between the toes, in between the web spaces of the fingers, nails, etc. Just remind your patients it's not in the main wing of IMED, but in the left wing or the older side or the old Southern Radiology side.